Acute kidney injury is often diagnosed when a patient is noted to have azotemia. The elevation of the blood urea nitrogen, or BUN, and serum creatinine represents a decline in glomerular filtration rate, that is, GFR, but in a few cases, it may reflect increased production without any reduction in GFR. By the end of this topic, you should be able to define acute kidney injury, identify the various etiological factors of acute kidney injury, discuss the diagnostic approaches and general management of acute kidney injury, describe the prevention strategies of acute kidney injury. Acute kidney injury, or AKI, previously called acute renal failure, or ARF, is the sudden drop in kidney function, encompassing both injury and impairment, over days to weeks, resulting in the retention of waste products that are normally cleared by kidneys. The term acute renal failure was used in the past as a failure of the kidney to function, resulting in severe azotemia and oliguria/anuria. After extensive research, it has been found that even milder reduction in kidney function with mild elevation in serum creatinine with or without oliguria is associated with serious clinical consequences. Hence, the newer term, acute kidney injury, indicates that this condition is a manifestation of several disorders that affect the kidney acutely. AKI is the designation for a diverse group of conditions, including some specific and non-specific kidney diseases, as well as some extrarenal pathologies that share common diagnostic features, like raised serum creatinine and reduced urine volume. It incorporates the entire scale, from trivial changes in renal markers to a need for renal replacement therapy. Sometimes, directly after the insult, serum creatinine and blood urea nitrogen remain normal. In such cases, the sign of AKI is reduced urine output. AKI is not a structural entity, as sometimes there may be an acute decline in renal function without any visible renal parenchymal changes. The term acute kidney injury has mostly substituted acute renal failure after it has been found that a slighter decline in renal function is clinically relevant, as is associated with increased morbidity and mortality. Several different criteria have been used to define acute kidney injuries, like KDIGO, or kidney disease, improving global outcomes, rifle or risk injury, failure, loss of kidney function, end-stage kidney disease, and AKIN, or acute kidney injury network. According to KDIGO criteria, AKI is defined as the presence of one or more of the following. First, increase in serum creatinine by 0.3 milligrams per deciliter or more within 48 hours. Increase in serum creatinine to 1.5 times or more the baseline that is known to have occurred in the past 7 days. Urine volume less than 0.5 milliliters per kilogram per hour for at least 6 hours. Staging of AKI is appropriate because the outcome depends on the stage of the disease. Depending on the volume of urine and serum creatinine levels, the AKI has been staged according to AKIN, KDIGO, and rifle criteria. If serum creatinine and urine output fall under different stages, the highest stage must be considered. AKI is seen as a complication of 5 to 7% of acute hospital admissions and 30% of ICU admissions. According to some prospective cohort studies, patients with AKI are at increased risk of mortality from all causes despite renal recovery. The incidence in the US is estimated to be nearly 500 per 100,000 people per year. The rates of AKI have progressively increased since the 1980s and continue to rise. Although AKI is an acute condition, as the name suggests, it is greatly associated with increased development of chronic kidney disease, especially in those who required dialysis during the acute episode. Both incidence and leading causes of AKI greatly vary between developed and developing countries. The incidence of AKI is often underestimated because of the lack of a single standard definition. It is more so in developing countries because of underreporting and non-referral of cases to hospital. In developed countries, the prevalence of hospital-acquired cases is up to 15%. In a recent study, the incidence of AKI in community is estimated to be up to 4.3% of total hospital admissions. But it is expected to be more than this number because of underreferral of AKI cases. The leading community-acquired causes of AKI in developed countries are volume depletion, heart failure, adverse effects of medications, urinary tract obstruction, and malignancy, whereas those in developing countries are snake/insect envenomation, infections, and crush injuries. The usual hospital-acquired causes include sepsis, major surgeries, nephrotoxic medications, etc. The leading causes also vary with age. In the pediatric population, volume-responsive causes like diarrhea and blood loss are more common. In elderly, AKI is more common than any other age group, and it has been found that there is an age-dependent relationship between AKI and older age. This is both due to impaired renal function with advancing age and development of comorbidities, like hypertension and diabetes mellitus. Moving on, we will cover the etiology of AKI in next lesson.